My name is Diarmuid McCoy. My specific interest is the management of chronic non-cancer pain. This has been an interest of mine over almost 2.5 decades. I started off out of the profession of anaesthesia and pursued pain medicine in Flinders University in South Australia. So in my clinical work, the patients that I see are those who have got injured in the line of their work, injured in motor vehicle accidents, or in accidents outside of these two spheres. I also see patients who have been injured as a result of the military, training, and in everyday accidents. There are a number of patients who we also see because of degenerative diseases, such as osteoarthritis, or medical conditions which cause pain. So it is from a huge spectrum of patients that we see them. These patients often come from industry or motor vehicle accidents and present with a whole variety of musculoskeletal and neuropathic pain. They are patients whose lives have been significantly changed by their pain. They have suffered losses, physical, mental, psychological, social, and financial. And so we try to ameliorate their situation, taking all of these elements into consideration. In layman's terms, what I do is, for patients who are presenting to me with non-cancer persistent pain, and that is pain that persists for in excess of 3 to 6 months or long after it is expected that it would resolve. I see them take a history, do an examination, which is going to be part of the psychosocial biomedical approach. So there will be an assessment from a psychology perspective, from a physiotherapy perspective, and from a medical perspective. And putting all of these elements into place, put a plan of action together so that they can optimally achieve the function that they can expect. The personal interpatient aspects of what we do is of primary importance to me and to those who I work with. It is the essence of medicine to relieve a patient's pain. That is what doctors have done for many centuries. What we can do is take the psychosocial biomedical approach, taking each of these elements in turn, try to improve the patient's lot, their function, their interaction, and their physical health. The things that I enjoy working with these patients is getting them back to being functional members of their family, of society, and of the workforce. And if they can't rejoin the workforce, then at least get them back to the paid workforce in some form. The clients that would be referred to see me would expect to have their case heard with justice, fairness, respect, and with speed. So the referrers to my service can expect a rapid turnaround of an accurate, fair, and comprehensive report. The things that excite me now about it is that those assumptions that we made about patients with persistent pain are untrue. The therapies that we can now offer them are scientifically based, and the biopsychosocial approach to the management of pain is increasingly being recognized as the appropriate treatment option. The case managers in personal injury are often torn between competing interests. I'd like to think that I would be able to bring some element of priorities into working through the patient's progress in terms of their pain and its resolution.